Hello everyone. In this particular lecture, we are talking about atrial fibrillation. Atrial fibrillation is the most common type of supraventricular tachyarrhythmia. So, in atrial fibrillation, there is uncoordinated contraction or depolarization of atria, which are not sustained enough to produce any significant cardiac output that leads to irregular ventricular response. The main risk factor for atrial fibrillation can be grossly be divided into cardiac and the non-cardiac heading. Under cardiac risk factor, they includes hypertension, diabetes mellitus, obstructive sleep apnea, any coronary disease, cardiomyopathies, valvular heart disease, including most common mitral stenosis and Wolff-Parkinson-White syndrome. Non-cardiac risk factor for atrial fibrillation includes hyperthyroidism, pulmonary causes like COPD, pulmonary embolism and pneumonia, cocaine, pheochromocytoma, and hypomagnesemia and hypokalemia is the electrolyte imbalance. Therefore, the thyroid disorder must always be ruled out in patients with new onset atrial fibrillation. American Heart Association has divided atrial fibrillation into four different stages. The stage 1 atrial fibrillation means those atrial fibrillation in which there are only the risk factor are present. The risk factor can be either modifiable or non-modifiable risk factor. And because of these risk factor, if there is any structural or physiological abnormalities of the heart, then we call this stage 2 atrial fibrillation, which is also termed as pre-atrial fibrillation. And stage 3 atrial fibrillation includes paroxysmal atrial fibrillation, which means the atrial fibrillation that lasted for less than 7 days and it resolved either spontaneously or with the use of medication. And persistent atrial fibrillation means that lasted from any duration from 1 week to 1 year. That's persistent atrial fibrillation. And long-standing and persistent atrial fibrillation means the atrial fibrillation which has lasted for more than 1 year. And successful AFib ablation means atrial fibrillation that has disappeared or resolved with the use of any ablation procedures, including radiofrequency ablation or ablation of bundle of phase. And stage 4 means the permanent atrial fibrillation in which there is any poor or inadequate response to treatment. And the main pathology of pathophysiology of atrial fibrillation is mainly because of the primary trigger. The trigger can be in the form of automatic foci near the ostium of pulmonary vein within the left atrium, or because of any fibrotic atrial tissue, or because of any aberrant pathway, like in case of Wolff-Parkinson-White syndrome. All these pathology will lead to electrical remodeling of the heart of mainly left atrium. This electrical remodeling will be seen within few hours of this original insult, and that leads to structural remodeling, and this structural remodeling will be seen in the matter of month in the form of atrial fibrosis and dilatation. This atrial fibrosis and dilatation will now act as another trigger that leads to self-sustaining of these foci within the left atrium. That finally leads to aberrant contraction of the atrium. However, the contraction is inadequate and ineffective, and that's mainly chaotic and uncoordinated contraction. That leads to stasis of blood within the left atrium, which finally increases the risk of having thromboembolism and stroke. So the clinical features of atrial fibrillation can be in all patients, whether the patient is hemodynamically stable or unstable. In all patients, we can see something called apex pulse deficit. So apex pulse deficit means we are auscultating the heart rate. We are calculating the heart rate by auscultation, directly by auscultation. So because of these uncoordinated contraction, auscultation will of course be number of heart rate on auscultation will of course be greater. However, all those contractions are not significant enough to produce a significant palpable pulse. Therefore, there will be the deficit. Therefore, the number of pulses won't correlate exactly equal to the number of apex beat, and it will be more than 10. So if apex pulse deficit is more than 10, then it is strongly suggests the person might be having atrial fibrillation, and the pulse will of course be irregular in nature, and person can be asymptomatic as such. Sometimes person can present with palpitation, fatigue, dyspnea, and syncope, all because of decrease in cardiac output because of those atrial absence of atrial kicking. And in cases of hemodynamically unstable patient can present with ischemic chest pain, acute heart failure, pulmonary edema, cardiogenic shock, and altered mental status. Sometimes patient might present with the complication of atrial fibrillation is the first episode of atrial fibrillation, including stroke and TIA. Sometimes patient can present with end-organ infarction, including renal infarction, splenic infarction, and peripheral artery disease, and patient might present with tachycardia-induced cardiomyopathy. The investigation of choice. First investigation is we always do 12-lead ECG. In ECG, we can see there will be rapid ventricular response in the form mainly more than 110. And if the patient is having long-standing atrial fibrillation, where his AV node has already entered into the stage of fatigue, or if the person is under beta blockers or non-dihydropyridine calcium channel blockers, which are AV nodal blocking agent, then patient might be present in with bradycardia and irregular pulse. The rhythm is of course irregular. However, if there is atrioventricular dissociation, the rhythm can be regular as well. And of course, there will be absence of P waves. In the absence of P wave, we can see something called fibrillatory waves or F waves. So fibrillatory waves gives a brief idea whether the atrial fibrillation is acute in onset or it has been standing for a very long duration. If the F waves are quite prominent, then the atrial fibrillation is quite acute in onset. And if the fibrillatory waves or F waves are of low amplitude, then this atrial fibrillation has lasted for a very long duration. And of course, there will be narrow complex QRS. And regarding management of atrial fibrillation as such, we classify the management whether the atrial fibrillation is of new onset or it's the long-standing atrial fibrillation. In new onset atrial fibrillation, if the patient is hemodynamically unstable, we do straightforward something called immediate synchronized cardioversions, and we anticoagulate the patient. However, we don't delay electrical cardioversion just for the sake of using anticoagulant. In hemodynamically stable patient, there are the maneuvers like rate controls and rate versus rhythm controls and long-term use of anticoagulation. So for hemodynamically stable patient with atrial fibrillation, if the atrial fibrillation is unsafe within 48 hours, then we do electrical cardioversion as soon as possible, and then only we calculate Charvas score. If the Charvas score is 0 to 1, then we don't need any anticoagulation. If the Charvas score is more than or equal to 2, then we initiate anticoagulant. And if the atrial fibrillation is lasting for more than 48 hours or of unknown duration, or we don't precisely know for how many hours or for how many days is the patient is under atrial fibrillation, then we have the two different options. We can either go straight forward with transesophageal echocardiography to look for any intracardiac thrombus. If an intracardiac thrombus is not seen, means the patient will have low risk of having stroke or the thromboembolic event. Then we can do straightforward electrical cardioversion, and after doing electrical cardioversion, we continue anticoagulant for at least a duration of 4 weeks, and then we assess Charvas score. If the Charvas score after 4 weeks is 0 to 1, then we discontinue anticoagulant, and if the Charvas score is still more than 2, then we continue anticoagulant. And the other option is we can give a trial of 3 weeks of anticoagulant, and then only we can do electrical or pharmacological cardioversion. So for the management for the use of anticoagulant, if the patient is having prosthetic heart valve or any rheumatic mitral valve condition, mitral stenosis, or the patient is having decompensated heart failure, then only proven option is warfarin. And for non-valvular atrial fibrillation, we can use either warfarin or directly acting oral anticoagulant, including dabigatran, rivaroxaban, and apixaban. For chronic atrial fibrillation, we have two different options: rate control approach and rhythm control approach. The rate control is preferred one because rate control decreases the risk of having tachycardia-induced cardiomyopathy. However, rhythm control can also be done, and the main goal of rhythm control is to maintain sinus rhythm of the patient. Under rate control, we can use the drugs like beta blockers, non-dihydropyridine calcium channel blockers, and digoxin. The target heart rate in patient with heart failure is less than 80 per minute, and the target heart rate in patient without heart failure is 100 to 110 per minute. For rhythm control, we can use pharmacological treatment, like if the patient is having normal left ventricular ejection fraction, then the drug like dofetilide and flecainide are preferred one. And if the patient is having left ventricular with ejection fraction less than or equal to 40%, then we use drug like amiodarone and dofetilide. Here in this condition, we generally avoid the drugs like flecainide as such. So for the rhythm control, it's only used in patient or preferred in patient who are continuing to having symptoms like dizziness, palpitation, despite rate control approach. So the rate control is the preferred one. If the patient is not getting symptomatic treatment, isn't getting symptomatic improvement on the rate control, then only we prefer rhythm control. And if rate and rhythm control, both pharmacological treatment, are not responding in a patient, then we can do something called AV nodal ablation therapy. We can either use radio frequency waves to ablate these ectopic foci, and if these ectopic foci are not the patient is not responding well to this radio frequency ablation, then we can do ablation of AV node. And before doing ablation of this AV node, we generally implant a permanent ventricular pacemaker in this patient. And another surgical procedure of choice is something called maze surgery, where we ablate these ectopic foci. We cut this ectopic foci so that there won't be any transmission, or there won't be maintenance of this ectopic foci as such. So with this, we conclude the management of atrial fibrillation as such. And thank you for your time and attention.